Hello, good afternoon. There's this delay because of some technical problems. I hope you all can listen to me. The topic for today's class is drug metabolism and elimination. What is drug metabolism? In bracket I have written biotransformation. Metabolism, I think we all understand, a drug or any substance which gets into the body changes its form. So when we say biotransformation, that means the form of the molecule changes in a living system. So biotransformation is a term which indicates metabolism as far as when we talk about drugs which are being used for therapeutic purpose or for any other diagnostic or any other purpose. Now, what is metabolism? That is chemical alteration in the chemical alteration of the drug in the body that takes place is called metabolism. So, drug changes from one form to another form. There is a chemical change. What is the purpose of metabolism? I think a living system or a human body or any organism has inherent property to remove whatever gets into the body from exterior. That means any foreign substance that gets into the body, there are mechanisms to get away with it, to remove it from the system. So you have immune mechanisms to take care of some antigenic things, which are substances which are antigenic, but when a drug enters in the body, it is taken as substance and there is a mechanism in the body to remove it from the system. So when we look at metabolism, we see that a drug changes to its more polar form so that it is not easily absorbed and is excreted out. So non-polar or lipid compounds are rendered into polar or lipid insoluble compounds. So if it is lipid soluble, it gets reabsorbed, it can pass the membranes, and but when you convert or the body converts a non-polar molecule to a polar molecule which is more ionized and is not reabsorbed well, then it gets excreted out. So it becomes more water soluble and is excreted out in the urine, which is the main site from where excretion occurs. So what is the purpose of metabolism? Metabolism is changing a form of drug which can be easily eliminated from the body. A molecule changes to its more polar or more water soluble or aqua soluble form and is filtered out and excreted out easily. Now if we look at other hydrophilic drugs which are already hydrophilic in nature, there is no need to have a step of biotransformation. So biotransformation is not required, or they do not undergo biotransformation. Molecules which are already hydrophilic, which are already polar, so they are excreted unchanged as it is. So these are streptomycin and neostigmine are the examples. What are the sites where metabolism takes place? Primarily, if we look at the sites where metabolism occurs at a very high rate, these are the sites are liver, kidney, intestine and lungs. But that doesn't rule out that other sites do not metabolize any drug or any other substance. It is the rate of metabolism which is maximum at these sites, and we all know that liver is the primary site of metabolism. So although every cell has a machinery to metabolize, but the extent, rate and expression of certain molecules or enzymes is high at certain sites. So accordingly we say that liver is the site where maximum metabolism takes place. Now, what are the consequences of biotransformation? What happens when a drug undergoes biotransformation? First is the inactivation of a drug. So, most of the drugs, when they undergo biotransformation or when they undergo metabolism, they become inactive. So, when we say a drug has undergone metabolism, for most of the drugs, it is meant that the drug has become inactive, is not biologically active. So its form has changed, its properties have been changed, and its biological properties also are affected and it is not able to produce its action. The second aspect that covers transformation is that certain drugs are active by themselves and they undergo metabolism or biotransformation to another molecule, but the other molecule that is generated is also active. So that means active drug is producing a metabolite which is active. The third is activation of inactive drug. So there are certain instances where active drug cannot be given for various reasons. Maybe it is not safe to give active drug, maybe it produces more, it is not more stable or not palatable. So you opt for giving a drug in its inactive form, and what is essential is that body should have a mechanism to convert the inactive drug to its active form. So the inactive drug form which is taken is called the prodrug. So prodrug undergoes biotransformation and gets converted to its active drug or the active form of the drug which produces its biological effects. So if we give examples, we have cyclophosphamide which is converted to aldophosphamide which is the active form. I think you are all familiar with levodopa, which in itself is not active but is converted to dopamine, which is biologically active and is able to produce its therapeutic effect. But why levodopa is given when dopamine is the active drug? So there are various reasons that levodopa can cross the blood-brain barrier whereas dopamine cannot cross. So this property is made use of. Thereby levodopa is administered, it crosses the barrier and reaches the CNS. Then what is important that there should be a mechanism or enzymatic system available there to convert it into dopamine, which is the required molecule in the CNS. So there are various reasons for administering various prodrugs. I think two examples are here. I think in subsequent classes you will come to know of various other examples where these prodrugs are used. Prodrugs are also used for targeting the effect of a drug. I'll give you one example. For example, if you have an enzyme which you want enzyme to be expressed at certain sites, maybe for example, if you have drugs which are used for their anti-cancer properties, you know that these drugs, though they are effective, but they produce severe side effects. So these side effects are unbearable and you want that a drug must undergo biotransformation at the site where its action is required. So what is possible that you can get hold of an enzyme which can be directed to a site where effect is required. The enzyme can be administered by either a gene or its antibodies, or can be tagged with the antibodies, and with this antibody which may be against tumor antigens. So these antibodies, when they are tagged with an enzyme, they carry the enzyme or a gene which is required to be expressed at the cancer site. So you design it in such a way that it goes there and expresses, and then it can convert inactive drug to active drug at the site where action is required. So that makes it more need-based therapy, and then it minimizes the doses which are required to be administered and to reduce the systemic toxicity of the drug. So these are experimental studies, several of them are available. Targeting can be achieved by using this approach of administering prodrugs. Now, why do we consider these metabolites to be important when we talk about excretion of the drug? Now, when we look at the primary objective for metabolism is that a drug undergoes metabolism so that it can be easily excreted out. Now, if we look at biotransformation of paracetamol, I have just given you some values here, and we look at renal clearance, how system or kidneys are clearing the drug. If a drug is administered, like drug is paracetamol, you see 20 ml of plasma is completely cleared of paracetamol in 1 minute. But if you look at its metabolite, which is sulfate conjugate, you see this conjugate is excreted or eliminated to a greater extent, and 170 ml of plasma is cleared of this sulfate conjugate in 1 minute. So this is just a very simple representation to show that a metabolite is easily excreted out, so that more of plasma is completely free of the drug metabolite. Now, what are the different types of biotransformation reactions? How does it happen? What happens to the drug when it undergoes biotransformation? Broadly, there are two types of biotransformation reactions. There are non-synthetic or phase 1 reactions. These are the reactions in which metabolite may be active or may be inactive, and it involves the action of inducible enzymes. The second type of biotransformation reaction is synthetic conjugation or phase 2 reactions. So here you see a metabolite is inactive. So a conjugate that is formed is inactive and can be easily excreted out. So it is also possible that a drug undergoes phase 1 reaction or may undergo phase 2 reaction. It is also possible that a drug undergoes phase 1 reaction and generates metabolites which are further passed through this phase 2 reactions. So in a sequential manner it passes through phase 1 and phase 2 reactions. When we look at the enzymes involved in phase 2 reactions, which involves kind of a synthesis or synthesis of a conjugate, we'll just talk about the conjugates that are generated, and the enzymes are non-inducible in this case. Now, if we look at various reactions in the non-synthetic phase 1 reactions, you see a drug may undergo oxidation. So oxidation, I think as far as your chemistry knowledge is concerned, it is addition of oxygen or negatively charged radical or removal of hydrogen or positive charged radicals. So these are simple ways we can define oxidation. So a drug can undergo oxidation and its properties are changed. It becomes more polar and is easily excreted out. So what brings about these oxidation reactions? These are primarily carried out by cytochrome P450 enzyme system in the liver. I think I'm sure you are all aware of different isoforms of cytochrome P450. You have different types or isoforms of this enzyme. They are categorized based on their among the homology among the different isoforms. So first level of homology categorizes them as CYP 1, 2, 3, 4 isoforms. Second level of homology, you see they are denoted alphabetically. So 3A, here 2D. And then third level of homology, if you go down, you see another number. So you have CYP3A4, CYP2D6. So these are different isoforms. Several of such isoforms available, and for which you have specific substrates. That means every drug cannot be metabolized by all forms of cytochrome P450. There are certain drugs which may be better substrate for these enzymes. So if you look at some of the enzymes which are largely used for biotransformation reactions, these are CYP3A4 and CYP2D6. Several others which are available. If we look at certain drugs which are metabolized by oxidation using cytochrome P450, you have barbiturates, phenothiazines, paracetamol and steroids. Now the other type of reactions which are phase 1 non-synthetic reactions, these are reduction. So earlier we talked about oxidation, then you have reduction, which is opposite of oxidation. So it is removal of oxygen or addition of hydrogen or positive radicals. Again, cytochrome P450 enzymes are involved. You have several examples: chloral hydrate, chloramphenicol, halothane, which undergo reduction and their properties change. Then certain drugs undergo hydrolysis. So hydrolysis is the conversion of a drug to another form. Ester is converted with in presence of water to acid plus alcohol using enzymatic process involving esterases. So hydrolysis is one way of changing a form of the drug. Now, another example is cyclization. There are certain drugs which form cyclic structures. So they form ring structures, and then that is a part of biotransformation. So their properties change. So proguanyl cyclizes to cycloguanyl. Similarly, decyclization also occurs for certain molecules. So the ring structure which is already there, for example in barbiturate and phenytoin, you see the ring opens and the properties change. Now, second type of reactions are synthetic reactions. So far we have covered non-synthetic reactions. Then the second part is synthetic reactions, which involve conjugation of drug or its phase 1 metabolite which is generated. They conjugate with certain endogenously produced substances which are derived either from carbohydrates or amino acids within the body, and they form conjugates which are polar, highly ionized organic acids which can be easily excreted out either in urine or they are secreted in the bile. Now, if we look at various synthetic reactions that take place, the most important one is the glucuronide conjugation. So, you see glucuronic acid is generated, and a compound drugs with hydroxyl or carboxylic groups, they form conjugates with glucuronic acid, and they form the glucuronide conjugates which can be easily excreted out. The examples are morphine, aspirin, steroids. But it is also reported that morphine conjugates that are produced, glucuronide is still active. So there are certain exceptions, but most of the drugs, if you see the conjugation that takes place, produces compounds or conjugates which are not active. Now this another reaction which brings about conjugation is through acetylation. So compounds with amino or hydrazine residues, they undergo acetylation with the help of acetyl coenzyme A, and it is well known that there is genetic polymorphism when acetylation is taking place. So there are certain individuals which are fast metabolizers or fast acetylators, and then you have slow acetylators. What happens if a drug is administered like isoniazid or hydralazine? You see there are individuals who metabolize it very fast because the form of the enzyme which is present represents a form which is bringing about fast metabolism. So there are certain individuals which metabolize slowly or acetylate slowly. So that means if you can identify people who are fast acetylators and slow acetylators, you can change the frequency of drug administration, because if the fast acetylator you give the dose, it will be easily and quickly metabolized. That means after some time you see the drug has already been metabolized and no fresh dose has been administered. So to take care of that, it is good if you can identify fast metabolizers and slow metabolizers. You can change the drug administration frequency, or you may, if possible, you can change the drug as well. Then you have methylation reactions. So methyl group is added in drugs which have amines or phenol groups in the drug molecule. So they undergo methylation, like for example histamine and adrenaline. So cysteine is the methyl donor, methionine and cysteine are the methyl donors for these methylation reactions. Similarly, you have glycine conjugates which are being formed. So you have salicylates and other agents with carboxylic acid groups, they are conjugated with glycine. Similarly, you have glutathione conjugation. So these are again endogenously produced substances which form conjugates, for example with drugs like paracetamol. And if these glutathione is depleted, or the level of paracetamol is very high and this level is lesser to form a conjugate, you may come across toxicity occurring because of overdose of paracetamol. Similarly, for drugs which are purines or pyrimidines, you see there is formation of ribonucleosides, and such drugs are effective in cancer chemotherapy. Now, how these biotransformation reactions take place? Usually these reactions involve use of enzymes which are either localized on the microsomes or they are non-microsomal enzymes. The microsomal enzymes are associated with endoplasmic reticulum. These are mixed function oxidases and cytochrome P450 enzymes and bring about reactions like oxidation, reduction, hydrolysis, and only one conjugation reaction, that is glucuronide conjugation. You have non-microsomal enzymes which are present in the cytosol, which may be present in the mitochondria, and the enzymes which are involved in this non-microsomal pathways of metabolism. They include flavoprotein oxidases, esterases, amidases, and conjugases. So you see these enzymes also bring about oxidation, reduction, hydrolysis, and other conjugate, like I have said, conjugases. So conjugation reactions other than glucuronide conjugation, they are brought about by non-microsomal enzymes. Now, in last class, we made a mention of drug absorption, where drugs are absorbed from the GIT and they pass through liver and they undergo metabolism. I just have one slide to say that you have people who metabolize the drug slowly, or you have first pass metabolism, may be low in for certain drugs like phenobarbital, phenylbutazone, theophylline. The first pass may be intermediate for certain drugs, and first pass metabolism is very high for certain drugs. So you tend to use drugs which are not metabolized in the liver, or maybe like for this drug you use routes of administration where liver is bypassed. So this is a kind of metabolism which tends to metabolize the drug so that a sufficient drug or enough drug is not available to produce its effects, because it is undergoing metabolism when it is passed through the liver. Now, what are the enzymes, how these enzymes function in the liver? When we look at the activity of these enzymes, you see enzymes are inducible. The microsomal enzymes are inducible enzymes, and there are certain drugs which induce these enzymes. That means they enhance their activity and increase their effect when we look at the metabolism of certain drugs. So some of the drugs are categorized as enzyme inducers like phenytoin, rifampin, barbiturates. So if such drugs are taken, they tend to increase or enhance the metabolism. And what happens if other drugs are taken along with these drugs? You see, when phenytoin is given and drugs like digitoxin or quinidine are also given, you see enzymes are induced and they metabolize these drugs. So their effect is decreased. So their activity is decreased when they are administered with this group of drugs which are inducers. Similarly, if a user of oral contraceptives is taking rifampin, which is known to induce enzymes, you know that oral contraceptives are nothing but low doses of hormones. If enzymes are induced, the levels of these hormones go down and they lose their efficacy as contraceptives. Or if you are using one is using steroids, their levels go down because they are rapidly metabolized. So what happens? You need to give certain instructions to the users of oral contraceptives that since you are taking this drug, this oral contraceptive may not be effective. One may be advised for alternative means of contraception. Similarly, if someone is taking barbiturates, that is also a good inducer of enzymes, and drugs co-administered with barbiturates, they tend to show decrease in activity. Then there are certain drugs which are enzyme inhibitors. So these are chloramphenicol, sodium valproate, cimetidine, ketoconazole. So these are inhibitors which inhibit the enzymes. That means if a drug is co-administered with these drugs, if their metabolism is inhibited, their activity is enhanced. So their effect is more when they are given with this, because enzymes which are metabolizing these drugs have been inhibited. So these drugs are not being metabolized and are present in abundance to produce their effect. So their increased activity is observed. So what is important, that when two drugs are given together at the same time to a patient, one has to really assess why these two drugs need to be combined, whether that effect the required effect will be obtained or not, what is the combination, if combination can be, if in this combination alternative drugs are available, one can opt for, or alternatively one needs to adjust the doses when drugs are given in combination. Now, once a drug has been metabolized, it becomes easily excretable. So this is the purpose of metabolism, that whatever enters gain access to the body and is a chemical substance, it changes its form so that it can be easily excreted out. So now we have seen that drugs undergo metabolism, they change their properties and become more water soluble and can be easily excreted out. There are few drugs which undergo metabolism and their products or the metabolites that are generated, they may be biologically active, or inactive drugs undergo metabolism to produce active drugs. Now, once a drug has undergone metabolism and has changed to its more polar form, which can be easily excreted out, then there comes the next step of elimination. How drugs are eliminated? So I think we are all familiar that the primary sites for elimination, if we talk about, it is the kidney, where it is filtration and secretion and to some extent tubular reabsorption may take place. Then the site of elimination is liver, where metabolism takes place, and then substances may get secreted in the bile. Some vapor or inhalational drugs are exhaled out through lungs. Some amount of certain drugs, some certain quantities or small quantities may be present in the milk, sweat or saliva, though this is not considered as primary site for elimination, but certain drugs are present in these sites. Now we have seen that drugs are eliminated or excreted out through urine. Drugs which may not get absorbed or may be secreted back to the GIT, they are excreted out in the feces. There are gaseous or volatile compounds like alcohol or anesthetics, they may be present in the exhaled air. Some amount of drugs like rifampin or heavy metals may be present in the saliva and sweat, and certain drugs like ethanol barbiturates may be present in the milk. So one has to be selective in choosing drugs when they are being given to a lactating female. Now, if we look at certain examples, how much of drug is being excreted and how much of metabolites are being excreted, there are some examples mentioned here. You see, aminoglycosides, they do not undergo any metabolic transformation and 100% of unchanged form is excreted in the urine. For chloroquine, you see, unchanged form is also excreted in the urine to extent of 50%, and rest of the 50% of the drug is undergoing metabolism, and you have two kind of metabolites being generated to the extent of 25% each, and they are also excreted in the urine. So you see, unchanged drugs as well as metabolites are excreted in the urine. For drugs like rifampin, you see 30% of the drug is excreted in urine, of which 50% is unchanged and 50% is metabolite. 65% is excreted in the fecal matter, of which 50% is unchanged and 50% is metabolized, and maybe 5% is present in the sweat. Now, if we look at the excretion, the site of excretion, primarily it is the kidney, where you see glomerular filtration is the first process that brings about filtration of the the blood that is flowing through the kidneys. All non-protein bound drugs are filtered. So whatever is bound to the protein that remain restricted to the plasma, and the free drug is filtered out in the tubules. Lipid solubility is not important when filtration is taking place. So whether a drug is lipid soluble or insoluble will get filtered out. And this glomerular filtration depends on the renal blood flow and glomerular filtration rate. Now, next step is tubular reabsorption. So, whatever is filtered out, you see, depending upon the lipid solubility or extent of ionization at the pH of the urine, you see certain drugs or certain metabolites may get reabsorbed. So, the forms which are more lipid soluble, they get reabsorbed, and this is made use of. That means by changing the pH you can determine the extent of excretion of certain molecules. For example, if somebody has taken drugs like barbiturate or salicylates at a very high dose and you want to facilitate its excretion, what can be done? By changing the pH, by alkalinizing the urine, by giving sodium bicarbonate, you can have a form of these drugs which are more polar and can be easily excreted out. Similarly, if a drug is more alkaline in nature, this is for slightly acidic drugs and this is for slightly alkaline drugs. You can change the pH of the urine by giving vitamin C and bringing about acidification, where these alkaline drugs exist in its polar form and can be easily excreted out. So the pH of the urine can be changed to facilitate the excretion of certain drugs. Then there is a next process which is tubular secretion. So we have seen glomerular filtration, we have seen reabsorption. Now this is secretion. There are transport mechanisms or transporters available which bring about or facilitate the secretion of certain drugs. And you see there are drugs which compete for transport these transporters for their functions. For example, you have probenecid, which blocks the secretion of penicillin. Salicylates, they block the secretion of methotrexate. So they compete for binding to the transporters for their secretion. Now, what is the kinetics of elimination? We have just in a few slides earlier, we just saw example of paracetamol and we discussed about clearance. So when we talk about elimination, we don't say that this much of drug has been eliminated in unit time, but it is said that this much of plasma has been completely cleared of the drug in a unit time. So clearance is the rate of elimination or rate of elimination or plasma concentration of the divided by the plasma concentration of the drug. So it is the volume of plasma which is completely cleared of the drug, from which drug has been completely removed. So this is the formula which is used to determine clearance is the rate of elimination divided by plasma concentration of the drug. Now there are two types of kinetics which are normally seen in most of the drugs. You see first order kinetics and zero order kinetics. In first order kinetics, you see a constant fraction of drug present in the body is eliminated in a unit time, and majority of drugs follow this type of elimination kinetics. That means constant fraction. That means in a unit time you see half of the drug or 1/10 of the drug or 1/5 of the drug is eliminated. But when we look at zero order kinetics, it is constant amount of drug is being eliminated in unit time. For example, we take an example of alcohol. It is, let's say it is 10 ml is being eliminated in 10 minutes. So next 10 ml in another 10 minutes, next 10 ml in another 10 minutes. So that means if there is 100 ml of alcohol, it will take 10 minutes for first 10, 10, another 10 minutes for another 10. So that takes that much of time. So you see the half-life or the effect of the drug remains for a longer time because it is constant amount which is being handled. Whereas here I'll just give you an example in my next slides. And for drugs, it is seen that there is a shift of first order kinetics to zero order kinetics at higher doses because the body cannot handle drug in terms of its fraction being handled. Then it becomes to constant amount which can be handled, and there is a shift in the kinetics. Now this slide shows that if a drug at zero time is at this plasma concentration level, let's say it has been administered intravenously, you see over a period of time its level they tend to decline and is being eliminated out. So if we see there was level was 32, whatever units is plasma concentration, some few micrograms or per ml, it's not written here but it is the concentration. So from 32 it comes down to 16 in 2 hours. In next 2 hours you see it is reduced to 8. In next 2 hours you see it is reduced to 4. In next 2 hours 2, and then it is almost negligible. So what we have seen here, so in 2 hours time the drug has come down from its original concentration to half, from 32 to 16, from 16 to 8. So it is becoming half in this constant time which is denoted here on the x-axis. So this 2 hour is the half-life, plasma half-life, because in 2 hours its original concentration, if we take this, is reduced to half. If we take this, it is reduced to half. If we take this, it is again further reduced to half. And what we observe that in 1, 2, 3, 4, 5, nearly 5 half-lives, you see almost complete of elimination has taken place. So we consider that in 4 to 5 half-lives, almost all the drug has been eliminated from the body. So what is the significance of knowing half-life? So now from previous slide we have seen that half-life of a drug is the time taken for its plasma concentration to be reduced to half of its original value. So we have also seen that in 4 to 5 T half times, almost nearly complete elimination takes place. We have also seen that first order kinetics, half-life remains constant. A fraction is being eliminated, so the half-life remains constant. Zero order kinetics, if we look at, half-life increases with dose. You give more dose because body can handle only a fixed quantity. So more drug is given, more of the time will be required to remove this drug. So this is a summary of what we have just covered. Now what is the significance? Why should we know half-life of a drug? So once you know that how much time it takes to reduce to half, in how much time it is being eliminated, this helps us in calculating the dosing frequency. So you know how much of drug and after how long, how much time you need to give next dose. How much time is required to reach steady state concentrations, the concentrations which remain around a constant level. So once you give at a frequent calculated interval, you see the levels fluctuate around a given value. So that is called a steady state. And then how much of drug is required to give a maintenance dose. So certain drugs are given at a higher dose to initiate their effect, but then you need to give maintenance doses to maintain their further action. Now, this slide gives you examples of some drugs with their half-lives. You see, it may range, maybe for few drugs you will have in few seconds, few minutes, few hours, 4 hours, 40 hours, 60 hours, 3 weeks. So if the half-life is long, that means the effect of the drug lasts for a longer, the levels remain there for a longer time, thereby the effect also lasts for a longer time. And you will come across examples where you see a drug which earlier used to be a category of drugs which you see that they were taken 3 times a day, 2 times a day. You have newer drugs available with longer half time where the compliance is better because the drug needs to be taken only once a day. So the effect is seen for a longer time following a single administration. Now there's one aspect which I'll cover with this, that is therapeutic drug monitoring. Why do you monitor the level of the drugs? If you know the levels of the drug, then you can relate it to their effects or therapeutic effects. You have certain examples where you measure the levels of plasma levels of the drug and relate to their beneficial or therapeutic effects. It is useful where drug has low safety margin. That means a slight increase in dose may produce toxic effects. So that means you need to know the levels, how much drug is administered, how much levels are attained to minimize the occurrence of side effects or the toxic effects of the drug. Then there are certain individual where you see variation. The effect of the drugs vary in different individuals. Then you may try to correlate that with the plasma levels. For example, lithium and tricyclic antidepressants. Then if you come across a situation where someone is not responding to the drug for no apparent cause, then you would like to see the plasma levels, why no response is being obtained when the drug is being given. So though you would like to be sure whether plasma levels are, the required plasma levels have been attained or not, or else you will try to find out other reasons for not getting a response to the drug. Maybe in certain poisonings maybe though you give symptomatic treatment for various poisonings, but at in certain individuals or certain conditions where you see long-term toxic effects which are similar to chronic effects of toxic elements which have been taken like heavy metals or anticonvulsants. So then you may try to see or relate those effects with the levels or of the substances in the plasma. Then you may also come across situations where psychopharmacological agents which are being taken. You may come across patients who may not take the medicine at all, or they may be irregular and they may come and complain the drug is not effective. So in certain cases you may try to see the effects and then try to relate it to the plasma levels, and then you look at the patient compliance, that patient has taken the medicine or has not taken the medicine. But there are certain situations where therapeutic drug monitoring is not of much value. What are these conditions? You see, if a response can be easily measured, then you need not measure the plasma levels of the drug. For example, hypoglycemics. Hypoglycemics, their effect is easily indicated by plasma glucose levels. So this can be easily measured. Than measuring the level of the drug in the plasma, it is easier to measure blood glucose levels. Antihypertensives. It is easy to measure blood pressure and then you can say that the drug is effective as antihypertensive agent. Anticoagulants. So you measure the coagulation or coagulation time than measuring the levels of the anticoagulant in the plasma. So these are, if a measure or a response can be easily measured, you need not measure the plasma levels of the drug. There are certain drugs which produce their effect for a longer time. That means they have produced a kind of irreversible damage or inhibition of an enzyme. So these are called hit and run drugs. So they produce their effects and the effect lasts for a longer time. So there you need not measure the plasma levels, because once they have produced an effect, it will not relate to the plasma levels at all. Similarly, you have drugs which produce irreversible action like organophosphates or aspirin, higher dose. Then the effect lasts for a longer time. So you need not measure the plasma level. you have to wait for certain time so that the enzyme system or the mechanisms which have been inhibited, they are available again to function. And then if a drug has produced active metabolites, you need not measure the plasma levels of the drug, because the metabolite itself is also active, so you cannot relate the effect of a drug to the levels of effect of the drug with the levels of the drug in the plasma. So as far as metabolism and excretion is concerned, I think this chapter clearly indicates that metabolism is the pathway which converts one form of the drug to another form which may be active or in most of the cases inactive, and the drugs are easily excreted out. Thank you.